All right, good morning and welcome everyone. So it's my pleasure to introduce Dr. Tom Staiger to speak this morning. Dr. Staiger is a professor in the Division of General Internal Medicine and the medical director of the University of Washington Medical Center since 2009. He is a fellow of the American College of Physicians and a past chair of the Society of General Internal Medicine's Clinical Practice and Health Policy Committee. Dr. Staiger completed both medical school and residency in primary care internal medicine here at the University of Washington. He subsequently earned a certificate in medical management at the University of Washington in 2004. Dr. Staiger has extensive experience in operational quality improvement. His academic interests have included evaluating the role of anticipatory systems in improving safety in healthcare, the diagnostic evaluation of low back pain, promoting scholarship and quality improvement, and educating physicians regarding leadership and quality improvement. And so it is with this background that he's coming to us today. So please join me in welcoming Dr. Tom Staiger as he presents quality improvement and leadership in a complex environment.
Thank you, Serena, for that introduction. I feel very fortunate to have the opportunity to talk to you today about three subjects that occupy a considerable amount of my time and energy as medical director: quality improvement, leadership, and complexity. I have no financial conflicts of interest. So today I'll be talking about some of what have been identified as best practices in quality improvement and in promoting QI scholarship. I'll be introducing some ideas about an anticipatory theory of complex systems. It'll be sort of anticipatory theory or anticipatory systems 101. And then talking about how to apply some of those ideas to help influence leadership decision-making, improve safety in healthcare and clinical situations. So first, why engage in QI activities? We all have more than enough to do on a typical day, but first and foremost, it's a way of improving patient outcomes. It's a way of improving safety, it's a way of improving health outcomes, improving our equity in healthcare, improving patient experience, and improving the efficiency of care, both for the care we provide to our patients as well as for our care providers who work in our system. We've got, by lots of external measures at UW-MC and across UW Medicine, very good to outstanding healthcare. When CMS measures our care, when Leapfrog, when Vizient, formerly the University Health Consortium, assess our care, we do very well. But we also, in working with patients and working with our systems, all too often recognize that things don't work well always the way that we would like. So there are ample opportunities to engage in quality improvement and to do that in a scholarly way. Second, it's a way of working with interdisciplinary teams. I think many of us who engage in QI work find that the opportunity to work with diverse teams from across the medical center in different areas to be one of the most rewarding aspects of being engaged in QI. We get to work with different people, meet different people, get a team together and work to accomplish something together. It's an opportunity to improve skills in quality improvement, leadership, change management. And there are also ample opportunities for scholarship in quality improvement. And that's what I'm going to be spending most of my time talking about in this section. So Bill Bremner, Annalise Schleier, and a group of us did a survey of chairs of departments of medicine in the US and Canada on their attitudes towards whether quality improvement and patient safety activities ought to be taken into account for promotion purposes. The majority of the respondents said that yes, that should be taken into account for promotion. About half said that their current promotion criteria were not particularly useful. And around a quarter said independently in the comment section that there ought to be evidence of scholarship for people to be promoted for these activities. We did a follow-up to that in which we reached out to chairs and other leaders in departments of medicine to identify promotion criteria that had been used to successfully promote faculty for patient safety and quality activities. And we reviewed 20 such criteria to try and identify innovative language in those promotion criteria. We identified the following innovative practices. First, that there's explicit language that acknowledges the importance of quality improvement patient safety activities to the central mission of an academic medical center. Second, that the promotion criteria contain an explicit framework for evaluating the quality improvement and patient safety activities for the purpose of promotion. And third, that the definition of scholarship be expanded to include the scholarship of integration using Ernest Boyer's model from Scholarship Reconsidered for scholarship in general, that also includes the scholarship of discovery, of education, and of integration. In the next section, I'm going to share some of what have been identified by a couple of experts as best practices in doing rigorous quality improvement work for publication. First set of ideas is from Kaveh Shahjania, who's the editor of BMJ Quality and Safety, and gave this talk at Grand Rounds. It's also posted on an intranet website on improvement science. First, to plan from the outset to write up your project. Even if you don't ultimately write the project up, if you approach it that way, the project's going to be designed more rigorously. You're going to go to the literature, look for best practices, and wind up with a project that's more likely to be successful and that is more likely to be something that you'll be able to disseminate. It's a good idea to look at the Squire or Standards for Quality Improvement Reporting Excellence Guidelines, which were first published in 2008 and updated in 2016, that have a detailed checklist of what are best practices in reporting out quality improvement studies. Shahjania suggests that you think about starting to write the abstract when you're designing your project, so that you can think through what are you going to be reporting for your methods, what are your primary outcomes of interest, so that you have a rigorous project that you can evaluate. Second, he talks about being sure that you've got a theory for why the intervention is going to work and that you articulate that. Shahjania says that no one would ever publish a paper that said, we gave patients a blue pill and such happened. Readers need enough detail to know about the intervention that you have done to be able to understand it and figure out how can they translate it into their own setting, which is going to be different. It was one of the challenges with reporting out quality improvement work. But they need enough detail to know how can they take that work and translate it into their own setting. It's obviously important to capture a range of outcomes of interest, both quantitative and as well as qualitative if possible, on your main outcome of interest, but also on how well the intervention is working, so that people know you're planning on doing such and thus, this is how well it worked when we intervened in practice. And also to include potential negative impacts of your intervention. When we do care pathway interventions here at UWMC, we always include, along with length of stay and direct costs, which are often our primary outcomes of interest, mortality data, readmission information, to make sure that we're assessing for any potential negative impacts of the intervention that we are putting forth. You want to describe how your implementation plan changed, modified over time. Typically, these are done with Plan, Do, Study, Act tests of change, and rarely does the intervention plan stay absolutely the same from implementation onset to the end of the study. And typically, it's a good idea to capture that in real time, which if you're planning on writing up your study, you'll think more about doing, because it's a whole lot easier to have some place where you write down, we change this and that, rather than retroactively trying to reconstruct, oh yeah, we made this change, we made that change, when you go about writing up what you've done. And then finally, don't rush to evaluate something before your intervention is ready. You can have a very rigorous evaluation of an intervention that isn't ready for prime time, and you're just going to wind up wasting your and others' time with that. The next set of ideas come from a paper Daniel Goldman wrote on incorporating scientific quality improvement into everyday work. First, to work on projects that are important to patients and participating providers. This makes it more likely you're going to have something that you'll be able to report out, makes it easier to recruit team members in. I recall when I was first a faculty member, Doug Powell gave me the advice that choose your academic projects of things that you care about, because chances are by the time you get close to the end, you're going to be pretty sick and tired of working on them. And if it's something you really care about, at least that will keep you engaged. And I've recalled that advice a lot, and try and make sure to the degree feasible that I'm working on things that I really care about. You want to choose projects that have bold timelines and clear measurable aims. When a group of us took on what we called our infection prevention breakthrough goal a number of years ago, we had a goal of dropping CLABSIs, MRSA, respiratory virus infections, and ventilator-associated pneumonias by 50%. Took us 2 years to do that, but we were able to achieve what at the outset seemed like a pretty audacious goal, and then we were able to write that up and share it. On any of your projects, you want to have the best team available. These are people you're going to be spending a lot of time with. You want expertise from across the medical center, from across the department, and into health sciences and upper campus when possible and when appropriate. We've got an increasing number of individuals who have expertise in implementation science that can be helpful in helping to figure out how do you change people's behavior, get durable processes in place to produce the behavior change that you want. You want to have as complete a data as possible. Having incomplete data is going to make it a lot harder to write up a study and share it. And one of the ways, not the only way, but one of the ways to do that is to work on projects that the hospitals are already collecting data on. So on our Patients Are First dashboard that Rick Goss has helped to develop and share, there's data that we're capturing on all of those measures. There are other publicly reported measures that we are capturing data on, and we're happy to partner with individuals and groups to be able to help improve that data. We've got increasing amounts of information on race, ethnicity, language related to our quality outcomes. Those are currently displayed on part of the HarborView dashboard, but we're working on getting them more accessible to everybody. But that's data for our ambulatory metrics that we're capturing, and there's areas that we clearly would like to improve. So if you use data that we're capturing, it takes the burden off of you. It's a good idea to try and find projects which are either unlikely to require formal IRB approval because they will grant you exempt status, or at least in which the approval is unlikely to be a major barrier. Implementing best practices often will not require IRB approval. This is a complicated topic and can vary a little bit from site to site, so if you have any doubts about this, good idea to contact the IRB and talk to them about whether whether your particular study or project requires IRB approval. We are fortunate to have some of the best house staff in the world here at UW Medicine. Go house staff. And there are lots of things that house staff can do to assist with quality improvement projects and to help make them more rigorous and more likely to be published, including frontline ideas about what things need an intervention, theories about how to make an intervention more robust, study design, manuscript preparation. Here's a selected list of publications in which Housestaff have been a first author, and in some cases a first and second author, that range from one to do better capture of comorbidities to improve our acuity adjustments, work on standardized handoffs to improve quality and safety, survey of residents' perspectives on M&M conferences, one on improvements of venous thromboembolism prophylaxis, and then a final one on aligning institutional priorities by having Housestaff engaged in efforts to improve our clinical learning environment review objectives. It can be helpful to understand how to use what's called quasi-experimental research or Plan, Do, Study, Act research designs. Often in quality improvement work, it's going to be difficult, if not impossible, to do a randomization. These are study designs in which you don't necessarily have random allocation, but in which you can still come up with ways to address internal validity issues. So what you're trying to do is establish a relationship between the process changes, the interventions you're making, and variations in outcomes. The basic approach is that there are multiple measurements at baseline and then during the intervention. Variations on that are that you can have a non-intervention control, you can have a series of interventions, you can have an on-off intervention, and it's a good idea to have statistical process controls around the data reporting. So here's one example from a study that was published in BMJ Quality and Safety on a hand hygiene intervention, and you can see various time series with data here at different periods of time. We've got the statistical process controls, standard deviations around each data series, and then annotations on interventions along the way that help lead to a substantial improvement over time. A group of us that Chris Wong led that included Andrew White, Susan Merrill, and me took a look at the quality of quality improvement publications back in 2011. So we looked at 11 journals that publish predominantly quality improvement articles here, identified 145 articles after excluding commentaries and reviews, and categorized these studies into pre-experimental that included cohort studies, simple pre-post, case series where they didn't have statistical process controls, into quasi-experimental along the lines of what I just described, and then experimental with randomized controlled trials. There were 3 reviewers. What we found was that the vast majority of studies were pre-experimental, that most of the research is at least at that time, was non-interventional, so cohort, instrument development, cross-sectional. And that in the interventional studies, that most were pre-post and case studies, qualitative case studies with interventions, and the relative minority had stronger methodologies. So we concluded that the quality of quality improvement studies, at least at that time, was less than optimal, that more rigorous designs would improve the quality of published QI activities, and that an increased use of the Squire guidelines would help promote more rigorous studies in quality improvement. We are exceedingly fortunate to have the Center for Patient Care Quality and Safety here at UW Medicine, co-directed by Annalise Schleier and Tom Gallagher. It is an outstanding resource for assisting with your quality improvement projects to help with design, improve the rigor, provides educational offerings, including a certificate in patient safety and quality that's offered annually. Would very much encourage you to avail yourself of the resources. Tom Payne's one of the members of the center, and we've got lots of folks who have great expertise in study design and implementation. And then going to end this section with a reminder that not all scholarship is peer-reviewed publications. If you're doing, disseminating tangible, high-quality, peer-reviewed knowledge with rigorous methods, that's scholarship. You can do that by presenting at regional or national meetings with posters, workshops, lectures. You can disseminate and develop curriculum and other educational materials. And then also, it's a good idea to preserve the results of your QI activities to demonstrate your leadership and service roles in your organization. And then there's an example at the quality portfolio in the Society of General Internal Medicine Academic Hospitalist Task Force for this. So next I'm going to turn to the second section, which I'll warn you, this is going to have some theory. It's going to cover a lot of territory, I will say. So hang in there. I don't expect you to necessarily follow all of what's going to be in here. I'm going to be presenting things that I've been thinking about in some cases for decades. Hang in there. In the final section, it's going to get translated into implications for our clinical settings. So first, I'm going to just take a little bit of time and describe how I happened to get very interested in complexity. In college, a couple of college friends who are now physicians and remain good friends and I planned a trip to go travel, and we weren't quite sure if we were going to go to Kenya or Nepal, and we arranged to meet in Morocco, which we did. Because of a lost passport, border closings, and communications that didn't get through, we got separated. And so I wound up traveling on my own and with people that I met along the way across North Africa, up through Italy, through Asia, to Nepal, back, and back to England and home, and met up with these guys about 7 months later. This was a time when for $50 it was possible to get a bus ticket and train tickets and get to India with about a week's worth of travel. So there were a fair number of people taking that path along to meet and travel with, so on and so forth. Had a fabulous experience, lots of memories from that. But a couple of things have stayed with me from that trip that have influenced my life to this day. One of which is that it confirmed my preliminary interest in becoming a physician based on the medical needs and opportunities that I saw in that part of the world. Second, I came back with a strong sense that there was something missing from what I had been taught up to that point about the natural world. I wound up following up on those questions by getting an independent major that I think is probably the only one that has been awarded in this, on history, mythology, and the ecology of ideas. Sort of a self-designed history of ideas major. The history part was to try and figure out a little bit of how come the world came to look like this today. The mythology for trying to figure out a bit of how come people think so many or believe so many different things strongly in many cases. And the ecology and the ecology ideas came from work of Gregory Bateson, who was an anthropologist and pioneering system theorist who wrote, amongst other things, Steps to an Ecology of Mind and Nature. And as I was trying to reconstruct what for me was a coherent view of the world, I found particular affinity for some of Bateson's works. He was interested in understanding how organisms represent and organize the world around them, information processing in nature, and he proposed that mental or informational processes are integral to our natural systems. When I got to medical school, I had an interest in applying Bateson's work to some of the biopsychosocial model and maybe updating it with some concepts from there. Had some conversations with Tom Inouye, who was the general medicine division head at the time, about physician-patient communication and the physician-patient relationship that ultimately led me to have a strong interest in theoretical biology, in particular in this theoretical biologist, Robert Rosen. Rosen wrote over 250 scientific articles and published 3 books that I'll be referencing here, and helped found an area of biology called relational biology that's interested in understanding how organisms are, essentially the organization of organisms and what helps organisms exist. Rosen wrote a lot about complexity, so I'm going to start by just covering some of what are generally agreed upon ideas about complexity to the degree that there's agreement about complexity. One is that all of the components in a complex system are related. Second is that decomposing those components leads to information loss about the system. And third, that complex systems are somehow greater than the sum of their parts. And that sometimes gets referred to as emergence, although I'm not sure I've ever heard a particularly coherent explanation of how emergence tends to emerge out of these systems. So Rosen takes a somewhat similar approach, but in a much more rigorous way to defining simple and complex systems. So simple systems he defines as ones in which all the information can be captured in a largest formal model. I'll talk a little bit about formal models on the next slide. And ones that can be fractionated into parts without losing information. A complex or living system is one in which no single formal model or finite set of models can capture all of the information about the system, and in which fractionation always destroys information about the relationship of the components of the system. If one has sufficient skill and took a clock, one could disassemble a clock and put it back together and the clock would still work. If one tried that with, for example, a cat, one would not wind up with a cat after disassembling it. I decided not to tell my cat I was going to share this example. Here's a depiction of the formal modeling relationship. Rosen wrote his first book about this, so I'm not going to do justice to explaining it in its entirety. But if we think about a natural system here, say we were going to drop something from top of the desk and wanted to model that, make predictions about what was going to happen as that object dropped, we would be over in this part. If we had enough skill, and it took a long time for somebody to do this well, we could translate that natural system into a mathematical formal system, use that mathematical system to make predictions, and then if it's translated back well enough, those predictions will be something that will tell us what's happening in that natural system. The best example of these are classical and modern models of physics. So when Newton developed classical mechanics that he published in the Principia, one of his key discoveries and allowed him to develop the models of classical physics is what's called recursion. And what recursion is that what is occurring at any given time, the position, velocity of a set of particles, and the forces acting on that system is what determines what happens at the next instant in time. And this happens iteratively, so over and over. Next instant in time is determined by what's happening now. And what Rosen said is the central feature of recursion is that it is converting the present into the future, and that the future is caused by the present. That's how these systems work. This has become more or less a universal way of us understanding systems and science. When quantum mechanics and relativity were developed, even though had major changes in physics, they still follow this dynamic systems paradigm. And it is how we tend to view other systems, chemistry, organisms, ecosystems. If an organism is a biochemical machine, that can be broken into parts and reassembled without loss of information and is a simple system, then this state transition dynamic systems paradigm is a completely accurate way of understanding organisms. But if organisms, ecosystems, other living systems are complex systems, as Rosen and many others would argue, then that dynamic systems paradigm is an incomplete model for understanding biology and other complex systems. One of the features of this dynamic systems paradigm is that the future can't affect the present. What the future is determined by what's happening now. What is happening in the future can't be affecting the present state. That's not built into this paradigm. So here is a diagram from Rosen's Anticipatory Systems book of that title, of an anticipatory system. And what it is defined there as is a system in which there's a predictive model of itself and or its environment, which allows it to change state in an instant according with the model's predictions pertaining to a future instance. So if we look here, maybe the dotted line boundary is an organism. We've got some metabolic pathway here, modeled as S. M is a predictive model of S that goes faster than real time. So that any given point, M is a model of a future state of S. An imperfect model, but it's a model of it. If that's coupled to an effector that can act on S or into inputs on S, that's an anticipatory system. The effector can also revise the M, the predictive model. But this is an anticipatory system as first described by Rosen in 85. The anticipatory theory of complex systems is that this capacity for anticipatory modeling is a fundamental characteristic of all complex systems, with the exceptions of viruses and prions, and that's because they can harness the anticipatory frameworks of their hosts. So I'm going to give a couple of examples of anticipatory systems to try and illustrate this, one from biochemistry, one from organizational behavior. And I'm going to use feed-forward metabolic pathways to illustrate this. So feed-forward metabolic pathways have been defined as the anticipatory effect that one intermediate in a metabolic or endocrine pathway has on an intermediate farther down the pathway. Glycolysis is one example of a feed-forward metabolic pathway. So here I've got the glycolysis pathway. For those of you who may be getting PTSD because you have memorized this and forgotten it more times than you care to recall, I'm not going to go into great detail here other than to point out three of the molecules in this pathway. First is fructose 1,6-bisphosphonate, which upregulates pyruvate kinase enzyme later on in the pathway. Pyruvate kinase helps catalyze phosphoenolpyruvate. At any given time, fructose is a predictor of states of phosphoenolpyruvate further down in the pathway. And by upregulating pyruvate kinase, it can help keep phosphoenolpyruvate levels within some target range. If we translate this into this anticipatory systems framework, phosphoenolpyruvate would be S, fructose 1,6-bisphosphonate is M, and pyruvate kinase is E, acting on phosphoenolpyruvate. In organizations, which Rosen was primarily focused on organisms, but also talked about some of the parallels and analogies between other organized systems outside of biology, including organizations. In organizations like UW-MC, we are continuously challenged with trying to manage capacity, flows, budget planning, space planning. The better that we can model the future through a combination of predictive analytics, information processing, but also through scenario planning, anticipatory models, the better that we have a picture of what the future is going to look like, the better decisions we can make in the present to achieve the outcomes that we would like. In patient care, the better that we know down the line what somebody's prognosis is, the better we can advise them to help give them guidance on decisions in the present to try and get to preferred outcomes. I'm going to end this section with reference to an article that Rosen wrote on feed-forwards and global systems failures. And in that, he said that in a simple system, like a machine, that when it fails, it's always because the components or parts of the system fail. In a complex system, they can fail when their components or parts fail, but they also fail when their models break down. So bad models are a risk for a complex system failing. In this last section, I'm going to make the assumption, which I recognize is an assumption, that the anticipatory theory of complex systems is correct. And if that is the case, talk about what some of the implications for patient care situations would be. This next section comes from something that Brenda Zeeler, Aaron Blackney, Kurt O'Brien, Ross Ehrmantraut, and Trish Critic and I wrote to explore what happens if you apply these ideas and what would be the implications for clinical settings. First, if a complex system, you can't have a fully accurate model of the system. Our clinicians, clinical teams, leaders' models of the complex system, be it a patient, the organizational unit, are never going to be completely accurate. And we will never be able to have a fully congruent model of a complex system between, patient and physician, between a clinical team and the patient. In a simple system, we could have an absolutely accurate model of what it's going to look like if I drop this pointer on the ground, but not with a complex system. Second, that we are continuously generating anticipatory models that we're using for planning and ideally to identify and mitigate high-risk situations. Given that any of us, whether we're in a clinical situation, in a leadership situation, if we have a sense that the analysis, diagnosis, plan is wrong, we should be speaking up and voicing that. I don't know if others in the room have had this experience, but I've had it myself more times than I care to think about, and I hope not to have it again. But when I get a sense, taking care of a patient, that something just isn't adding up right, I have learned that if I don't pay attention to that sense and track it down to the utmost, that chances are greater than I would like to think that something untoward is going to happen. So that is something I've both learned from patient experience, but also in exploring some of these ideas. Also, that the better our concordance between our models, the better likelihood of getting to preferred outcomes. So this is models of our current state as well as anticipatory, albeit imperfect models of future states amongst the clinical team, patients, families, leadership team members. And we see some of this referenced in the team steps, team training model that we use here at UW-Medicine. I think there it's called shared mental model, and working to have better communication to achieve a shared mental model. And we're going to have better reliability and concordance of our models if we've got team environments that encourage respectful sharing of information, including expressing discrepant views. This is a depiction of some of this. So we're generating lots of current state models all the time, models of what's going on here right now, anticipatory models of what's coming up. The better concordance in our teams between those models, the better we're likely to have preferred outcomes. And that in clinical situations, that including input from patients and families will help us get better concordance of our models. And that if we pay attention to discordant team perspectives, that we are going to be able to identify some high-risk situations and hopefully mitigate them to reduce the likelihood of future untoward outcomes. From a healthcare institution standpoint, these ideas support that healthcare institutions should be providing systems to support teams, anticipatory predictors of risk deterioration, that we should be encouraging teams to plan based on these predictions, and that we should be reducing the barriers to sharing information in these practices. Here on the right, we've got the IPASS tool that we use in our core system to help encourage both this situation awareness of the current state as well as contingency planning to anticipate future issues. Institutions should be providing support for structured clinical rounding, which we do on many of our services in medicine and elsewhere here at UW-MC, that we should be involving patients and family members, ensuring opportunities for good information sharing and raising of concerns, and that we should be paying attention to situations where there's divergent models and that may be a risk to adverse patient outcomes. Maybe it's not that the patient's difficult or the family's difficult. Maybe we're missing something as we sort through a clinical care situation, and we should be paying attention to those divergences. Also would argue that we should be providing very robust support for our clinical analytics and risk stratification tools that are largely information systems based to help guide our clinical decisions. We're currently doing this for sepsis, readmissions, clinical deterioration models. In a chapter that Trish Critic, Gong Lu, and Peter Tarsi-Hornick and I wrote for Handbook of Anticipation, we also talked about the opportunities to combine those increasingly robust predictive analytic models with inputs from human decision makers from our anticipatory models to help better inform our decisions. So in the last section, I'm going to just run through a bit of how some of this relates to things that we see in clinical practice or that's found in the literature as listed here. So this is a picture of our daily safety brief. We have this at 9 o'clock Monday to Friday at UW-MC. We have 20 or 30 leaders that gather for 20 or 30 minutes to share safety events from the last 24 hours, anticipated safety events for the next 24 hours. We use this to get a shared mental model of things that are going on, improve communication, do contingency planning, and it's been an extremely effective way of improving operations and helping with our safety. Team steps, as I mentioned earlier, the evidence-based toolkit developed by ARC and Department of Defense to improve team communication, and has principles similar to what I've presented in this anticipatory systems model, that we want to have good situation awareness, we want to promote good communication, we want people to be speaking up and voicing their safety concerns. This goes along with one of the elements of a culture of safety that we're trying to promote across UW Medicine, of psychological safety, that we want it to be safe for people to speak up, to voice their concerns. We don't want hierarchies to interfere with people speaking up, just like in an airline crew situation. Everybody is obligated to speak up if they've got something that they're worried about. We want it to be safe for everybody to speak up in our settings. There's a limited amount of literature on the value of clinical intuition or clinical intuition and anticipation in clinical care. One study looked at 3,300 children who were assessed based on history and exam as having a non-serious illness. And at the same time, the pediatricians were asked, independent of that, if they had some gut sense that there was something more serious going on. The kids were all discharged and followed for 24 hours, and then who was admitted within 24 hours was looked at. And that gut sense that there was something serious wrong, independent of the clinical assessment, was a strong predictor that they had a serious illness and required admission. There's a study that Mayo did where they found that nurses who were more experienced, not surprisingly, were a lot better at predicting physiological deterioration than those who were less experienced. They use this in their early warning system along with vital signs and labs to help improve the accuracy of that early warning system. They were initially calling it their nurse worry factor, but I think their risk managers made them change the title to something else. Here's an example from one study that I did to try and apply some of these to a clinical research setting. So Clarence Braddock, when he was here, and I developed a instrument to assess patients' agreement with their physicians on diagnosis, diagnostic plan, treatment plan. We were able to get this administered in a back pain study that Jerry Jarvik and Rick Dio were doing 1 month after the initial visit. And what we found was that better agreement between physicians and patients was a predictor of both better patient satisfaction but better functional health status outcomes at 12 months. I've always wanted to but haven't gotten around to doing something like this to figure out if disagreement at the time is a predictor of poorer outcomes down the line, and then whether that could be fed back to somehow identify and mitigate some of those situations. And then finally, there's a Handbook of Anticipation that was just published this year. Roberto Pali, who's the United Nations Education, Scientific, and Cultural Organization Chair in Anticipation, or Anticipatory Systems, edited this, gathers input from a variety of authors across the humanities, social, natural, and formal mathematics sciences about the theoretical foundations of anticipation as well as how to apply them. So, in summary, along with improving patient outcomes, engagement in rigorous quality improvement activities can enhance professional satisfaction and provide opportunities for scholarship and promotion. Anticipatory models, I strongly believe, are an essential feature of complex systems, and that it's important to have diverse and discordant inputs expressed about future concerns, because that can improve outcomes and mitigate risk in clinical settings. So there are way more people that I would like to thank and acknowledge than I have time to, but here's a list of current and former members of the Department of Medicine who I have had the privilege to work with as collaborators or mentors. There are others across the school and colleagues from SGIM that I've also greatly enjoyed working with. And then finally, want to close by thanking, acknowledging the support and patience of my family depicted here, my wife, 3 kids, and our son's girlfriend, and would close this by recalling something that an individual getting a career award at a Society of General Internal Medicine said, which was, if you keep the best interests of your family in mind as you make your career decisions, you will not be disappointed. I've got some slides with references for both of those sections here. And again, thank you for being here. And I think we have a few minutes for questions if anybody has questions.
Thanks so much, Tom. That was really great. So, issue that I've struggled with over the years, and I'm sure you have thought about too, is just how much harder and more complex it is to do QI work in the ambulatory setting rather than the inpatient setting. And wondering if you could sort of talk about those issues a little bit.
Yeah, great question. When we look back, quality improvement measures initially were focused on the inpatient setting, and it took us a number of years to gear up the infrastructure that we now have in place to improve quality on the inpatient side. The focus on ambulatory measures has exploded, as you are and many others are well aware, over the last 3 to 5 years. And we have at UW-Medicine not correspondently increased that infrastructure to fully address the challenges of the ambulatory setting. I think we're getting better at tracking data and including having race, ethnicity, language data for our various ambulatory measures that will be helpful, at least shining a light on opportunities. Figuring out how do you make changes in the ambulatory setting. I think many times we've seen the best results by focusing on the clinic processes and by involving some of our non-medical staff, non-physician folks in helping us make sure that we've got various things done that don't require physician input as one approach. But we've got a long ways to go to do a better job of improving quality in the ambulatory setting and getting our arms fully wrapped around improving population health in the ambulatory setting. But that's where we're going to increasingly be needing to focus over the coming decades.
Tom, I'm thinking of an analogy to sepsis. So 20 years ago there started being studies done where multiple interventions were changed at once and demonstrated improved outcomes. And then over the subsequent years, people ferret that out and find out that 2/3 of those interventions didn't do anything. How do you handle, when you're setting something up, the number of interventions that should be made? Do you want to make 20 interventions, changes all at once? Do you want to make just one? How do you handle that decision?
Yeah. One thing I learned fairly early on, I was asked to take on implementing medication reconciliation at UW-MC, and just to give you an idea of how naive I was, when I first heard about medication reconciliation, I thought, oh, that doesn't sound too hard. You know, like 5 years later, I was still working on it, but as we designed our first intervention on MedRecon, we were fortunate to have medicine chief residents at the table helping us design the intervention, and a couple of our medicine services who were willing to pilot test that. And we found that what we had initially designed was completely infeasible. So one strategy is to, both get good frontline input into what's going to be achievable, as well as to test that in a small group to figure out, can you actually accomplish that before broadening it out. And I think in general, having a good set of theories about why the interventions are going to work and how to go about them will tend to focus the interventions toward a set that are more likely to have an impact, and staying away from too broad a set of interventions that you're not going to be able to implement is a good approach.
Well, one of the criteria by which we're judged now is patient satisfaction.
Yep.
And is there any move to try to integrate that with actual data so that QI can inform that?
Good question. We certainly have on the outpatient setting patient satisfaction, as many of us know, to the physician level that's accessible through our Patients Are First dashboard. So any of you can go and look at my patient satisfaction if you click down into the ambulatory setting. So that data is available. Now, that said, and we don't have it, at the inpatient side, we have it on services because it's hard to get good attribution at the physician level. That said, it is known that there are a lot of factors that are independent of the quality of physician-patient communication, physician-patient relationship that will or can impact patient satisfaction. So, some of that, if somebody's upset because they've had to wait long in clinic to get in, or they're upset about their parking and some other things, those are going to potentially influence patient satisfaction. Some sociodemographic factors can influence patient satisfaction. There are lots of things that are outside of the control of a given physician that can impact that. So yes, we are and need to work on quality improvement in our processes, which will help support improving patient satisfaction, but I'm not aware of any efforts that we have underway per se right now to say if we do this quality improvement intervention in general that we're going to hope to see some change in patient satisfaction in this set of patients over here. It's worth looking at, but we don't have, other than some general education efforts and trying to improve our processes in general, anything underway right now that's exactly addressing that. Yeah. And that's a timely question because, as you are well aware, we're in the midst of budget purgatory here. Once again, it's budget season. So some of it is purely, I would say, analytic. We are forecasting and predicting based on using our information based on the first 6 months of the fiscal year 19, and we just carry that forward, and that becomes sort of our baseline. But then it is to some degree anticipation and judgment about what's going to change, what's going to grow, what are we at risk for not growing, that we have to use to make decisions about how to change that just straight line carry forward into something that where we think we've got opportunities here that we can provide some support to. We think it will factor out and can come up with a plan. So we are using a combination of informational processes and our own anticipatory judgments to figure out how to put together a budget that we think will work on behalf of the organization and our patients. It's an imperfect science.
Building on that, the question about sepsis, and I think this also ties to what our next Grand Round speaker will be addressing next week, which is big data. It seems to me that we have a chance to improve our predictive ability in determining who is going to decline clinically if we follow your advice and gather more information from a broader set of people about their intuition. A good example of this that enlightened me was that one model for predicting sepsis found a very powerful variable was how much of the tray of the dinner the patient had eaten 3 days earlier. And that isn't, vital signs, that's not leukocyte counts, but you can see why it might be important. And so now that we have access to larger amounts of data from larger collections of people, including those who take the tray away from the table, that gives us the potential to do even a better job. So it sort of fits into your theme and to next week's as well.
Yeah. I think paying attention to the things that we worry about and you know, figuring out, is that something that there's a good reason to be worried about it, or, you know, okay, we can set that aside, and capturing that. We've got lots of eyes and ears, and we're underutilizing them in many instances, and better utilization of all those eyes and ears could help improve our safety. Thank you.
Great. Let's give Dr. Staiger one more round of applause.